I became chair a few months ago of the PLG, and I'm really delighted to learn that this is a big focus for the BMA and look forward to the discussions. Thank you, Helena.
Thank you, Chrissy. May I ask you, Vic Rayner, please, to introduce yourself? I recognise that many people will already know you.
Oh, thank you very much, Helen. My name is Vic Rayner, and I'm the Executive Director of an organisation called the National Care Forum, which is a membership organisation for not-for-profit care providers. Our providers focus on a whole range of different areas of care, so home care, residential care, supported living, extra care provision, shared lives, a whole variety of different types of care across the sector. And I'm also part of something called the Care Provider Alliance, which is a body to bring together a wide range of representative care organisations.
Thank you, you're welcome. Next on my screen, I have Andrew Dilnot, whom I'm sorry, Andrew, I'm still quoting your evidence all these years later, but that tells you something about the lack of the funding. Many years ago, I did contribute to your evidence as part of the Standing Commission on Carers. Andrew, would you introduce yourself, please?
Yeah, when I first became interested in social care, I had hair growing over more of my head. So I'm delighted this is going on. I'm really looking forward to it. Social care is a terrible stain on our nation. It's delivered by wonderful people to people in great need, but it's not adequately funded. It's not adequately structured in all sorts of other ways, and it's not just funding that we need to sort out to move to a social care structure that does credit to the great people working in it and the people who need it. But at the moment, the funding is a critical part of it. Unless we have an appropriate funding mechanism, both for the means tested system and I think critically for the whole population, we won't get this right. And I'm as committed to this now as I was 10 or 11 years ago. I do think we've got a chance. I think the chance to get this done will probably be over the summer and autumn of this year. There'll be a decision made in the spending review in the autumn, and so I think we need to make sure somehow that we have as loud a voice as we possibly can in the middle and latter parts of this year.
Well, thank you for helping us with that. Next on my screen, I have Charles Tallock, please.
Hello, my name is Charles Tallock. I'm an Assistant Director at the Health Foundation and in charge of our new REAL Centre, which stands for Research and Economic Analysis for the long term. And what that centre is trying to do is to improve the quality of decision making about in particular about long-term issues. So we're looking at providing evidence and analysis to support decisions about funding, about policy reform, about workforce, and about things like the allocation of resources, potentially across to health and social care and across different parts of the kind of care journey. I worked with Andrew in 2010 and 11 because I was chief analyst of the Dilnot Commission, and then worked in the Department of Health as head of social care funding reform and was head of the social care analytics team. So I've also got a long-term interest and passion for social care.
Thank you. Next, Morgan Vine, please. Good morning.
Hi, Helena. Thank you. Hello, everybody. I'm Morgan Vine. I'm the head of policy and influencing at a national older people's charity called Independent Age. So we hear regularly about the things that people and their families are experiencing on the ground. And obviously, we really want the system to improve in lots of different ways. And just to echo what others have said, my passion for social care was trying to get support for my nan who had Parkinson's and Lewy body dementia, which for those who know is quite a nasty one, and trying to arrange her care was incredibly challenging. So that's why I'm interested in this area.
Thank you. And then I have sorry, next I have dyslexia, so there you are. David James, please.
Thanks, Helena. Yes, morning everyone. My name is David James. I'm the head of adult social care policy at CQC. I've worked in regulation since joining the Commission for Social Care Inspection back in 2006.
Thank you. And then I have Baroness Sheila Hollins. Lovely to see you.
Okay, hold on a sec. Can you hear me?
We can.
Good. So, well, it's nice to see you, Helena, too. I was president of the BMA, chair of the BMA Board of Science, and Helena will know that my passion and concerns are for disabled adults of working age. And I think it's so easy to forget that care is not just about older people, not just people my age and older, but people like my disabled adult children, the people that my charity Beyond Words works to try to support and empower. And care is so much about supporting people's independence, and that's been my life's passion.
Thank you. And then I have, if I may call you Danny Mortimer, please.
Yeah, everyone does call me Danny. Hi, everyone. My name's Danny Mortimer. I'm the Chief Executive of the NHS Confederation, which is a membership organisation for those that plan, commission and deliver healthcare in England, Wales and Northern Ireland. And as part of that role, I also chair a group of healthcare organisations called Health for Care, making the case for long-term plan, long-term investment in social care. And I also chair a group called the Cavendish Coalition, who've been working together across health and social care across the 4 countries, of which the BMA is a founding member, to look at the workforce implications that result for social care and health as a result of Brexit. Thank you very much for having me along.
Thank you for coming. And then I have Councillor Colin Noble. Colin, I have a recollection we may have met at the studios of Newsnight when the pandemic was starting and talking about social care in February or March last year.
Possibly. I don't know, there's so many different things you do that it's difficult to remember which ones you were doing and which ones you weren't. Delighted to be here. Really interesting group of people I think you've assembled, and it'll be fascinating to hear what people have got to say. For myself, background is I was a cabinet member for adult social care. I was then cabinet member for finance. I was then leader at Suffolk County Council, an upper tier authority in a 2-tier area. And I've been the County Council Network spokesman for health and adult social care. And I'm now in my 2nd term sitting on the Local Government Association Community Wellbeing Board. And I remember going back and sitting in the Central Methodist Hall when Andrew presented his report and saying, well, this all seems very sensible, let's just get on and do it. And many years later, and for my sins, I was the chairman of the association that selected a young Matt Hancock as its candidate. And I've sort of been chairman, president of his association for many years. So I get to bend his ear in different forums occasionally as well. So looking forward to it. Thanks very much.
Thank you. And then I have my friend Emily Holzhausen, if I may call you that, Emily.
Oh, that's lovely. What a lovely introduction. Thank you, Helena. So I'm Emily Holzhausen. I'm Director of Policy and Public Affairs at Carers UK. And we represent the unpaid carers, family members and close friends. So Helena and I have worked together with the BMA, and Helena's you've been such an important voice on unpaid carers that the health service really pays attention to the role of unpaid carers. So on social care, really, I think our objective is I can't underline how important it is for carers to be able to juggle their own work and care for their own health and well-being, for their own family relationships, not just the person who needs care directly. So it's an absolute lifeline. Thank you, Helena.
Thank you. And I then have Simon Bottery, please.
Morning, everyone. I'm Simon Bottery and I'm the social care lead at the King's Fund.
Thank you. You're very welcome. And then I've got some BMA colleagues. Caroline, please.
I don't know if you're thinking it's me. I'm Caroline Abrahams. You may have.
Sorry, I just got Caroline. I apologise.
Yes. That's all right. I don't work for the BMA. I work for Age UK. I'm the charity director of Age. My name's Caroline Abrahams. I'm the charity director of Age UK. I'm one of 3 co-chairs of the Care and Support Alliance, one of the others being my friend Emily, who we just heard from. It's my job to think and worry about social care, and I get plenty of ammunition for doing so, clearly. It's probably the area of policy where we're furthest away from where we would like to be as regards older people. Having said all that, I completely agree that this isn't just about older people, it's about younger disabled people, people with chronic illnesses, and it's also about unpaid carers. And Age UK and the Care and Support Alliance is worried about the issues for all of those. I am myself a part-time carer for my mum, and I have mystery shopped the entirety of the health and care system, so with and on her behalf. So I have some on-the-ground experience as well.
Thank you, Caroline. And then I've got James Bullion, please.
Hello there, good morning, Helena. Yes, so I'm James Bullion. I'm the president of the Association of Directors of Adult Social Services. So I'm one of 152 directors. We made 9 statements in the middle of last year about what we felt needed to be done in relation to adult social care. We very much see social care as very widely defined, not just about care homes, and with great ambition for our core legislation, the Care Act, which we think is pretty competent, but can't do much of its prevention and reduction and more proactive parts because of the resource constraint. And we think it's a great opportunity for us and the NHS to work together. I suppose we see this as our two sisters, the NHS and the social benefits reform, coming into being alongside social care in the 1940s together, and we just feel society's lost a bit of sight of the social care part of that triumvirate of legislation. So we have a sense of urgency around what needs to be done to fix the problem, but lots of energy around the economic contribution that social care makes, alongside the issues that others have described around care and dignity.
Thank you. And then I have Una Smythe. Good morning, Una.
Hi, yes, I'm Una Smith and I'm the CEO of Skills for Care. Sorry, it's one of those strange Irish pronunciations that people struggle with. We're the strategic workforce body for workforce development in adult social care in England, focusing on workforce intelligence for the 1.5 million people working in social care, workforce solutions and development and support to increase capacity and skills in the social care workforce. And I'm really happy to be here today, just particularly thinking about the future of that workforce, I think.
Thank you very much, Una, and I've learnt something with your Smith this morning as well. At the BMA, we've also got Greg Beals and we've got Lee Miller and we've got Rachel Evans. So I'm going to offer my apologies to them so that we can crack on. You should have received the agenda points and some questions that we sent. I would like to hear from as many people as possible, but you clearly may not have time or want to answer to everything. We're going to try and take questions from the usual raise your hand facility or from the comments in the meeting chat. So as you heard from Ivan, who chairs the Community Care Committee, I previously chaired it many years ago. The BMA has a long-standing issue in social care, but we haven't always been expressing that really to the benefit of our mutual patients and the people in the 4 nations. Our interest has, however, come out at almost all of our annual representative meetings where we formulate our policy every year. And we really have to get on with trying to get this done. As Andrew Dilnot says, I think we've got a window of opportunity potentially with a spending review. So the BMA have published a paper on the English social care future, and it has 4 overarching key calls. We want to have a boost in social care funding to improve the access to and the quality of the care that our patients get. We members want to widen the access to care services by making social care free at the point of need, and we want investment in the social care workforce and value of those who give us our social care. And we want a heightened focus on prevention and support for people to stay independent for longer. So I thought we would start with perhaps trying to discuss our key challenges on facing social care from your perspectives, so that we can listen and ultimately hopefully come up with some agreed actions so that we can put in joint ways of getting the window that Andrew Dilnot actually said of the comprehensive spending review, perhaps. I don't know who would like to open with what they see the key challenges are. And if you're not speaking, usual rules apply. If you could possibly pop yourself on mute. Vic, please.
Thanks. I mean, I'll come in just with a bit of I suppose, a perspective from those who are delivering care. So to sum up some of the challenges, and I know we're going to have a focus a bit later around the particular impact of COVID, but I think what COVID has done is accentuate and accelerate some of the pre-existing challenges. So I think we've got a situation where those who are needing care and support, the particular needs of those individuals have got much greater over the last 10 to 15 years, and the pressure therefore on the provision of care has been increased. So the kind of skills and expertise that are required within the social care sector in order to support people who, probably previously would have been either receiving hospital support or some other further kind of integrated medical and care provision is now all being sort of delivered separately outside within the care sector. So a greater level of need within there. Some significant restrictions around funding that are well documented by Andrew and many others over the years. The King's Fund will get a mention within there, I'm sure, and the BMA. So, very well documented kind of shortfall in relation to the funding required. There are very key challenges around recruitment, partly because of the low pay of the sector, but also because of the very low regard in which social care is held across communities generally, and certainly within the political sphere as well. It feels a lack of recognition for it, and I think a lack of understanding of the interplay, which I'm very pleased the BMA are calling for, between prevention and social care and health, and that understanding of that sort of spectrum of provision that needs to be enabled within communities. And certainly over the last 10 years, very significant reductions in the context of the kind of preventative support that communities and local authorities particularly were able to fund and support through programs like Supporting People, which has then meant that when people come into care services, come into contact with them, they're at a very much higher point of acuity and are much less able to achieve the objectives of social care, which are all around supporting people to live as independently as possible. So we're kind of in a situation where we're trying to achieve something that the wider system has essentially set up social care to fail at, because we're trying to provide independent living as sufficiently as possible for people, but without the resource or the kind of build up to it that would make the management of that much more effective. But I think, that being said, the opportunity within this context is that some of those things, particularly around public perception, I hope have been shifted, the notions around that within this latest pandemic, or this pandemic. Let's hope it's not the latest one. This pandemic. So actually, the opportunity to kind of shift the dial around some of that, I think, is definitely there, and we're really keen to see that happen.
Thank you, Vic. You covered a lot of ground there. If I could have James and then Sheila and then Danny, and I think, unless we've got new points after that, perhaps move on to what's needed to address it, please.
Thank you. So echoing some of what Vic has said, I'll try not to cover the same ground. I think the opening challenge, though, is one of understanding and vision. And I think, if anything, COVID has sent us backwards, that public understanding of social care is probably now associated with care homes rather than that much wider picture of disability, of freedom, of independence, and of family relationships, adults and children. And I really fear that we must do some really dedicated work that's about explaining what social care is and does. Many people know it when they see it, they just don't call it social care. So there's something about making sure that we explain that. Second challenge is the workforce issue. I think demographically, we have 18,000 odd businesses. Demographically, we need another 500,000 people working in social care who need to be attracted to go into that. More or less every young person leaving school has got to go into social care to cope with the demography, unless robots are going to come along anytime soon and sort of save us, which is not, not likely to happen at all, given the nature of what we do. So having an industry level approach to that workforce strategy is really essential, and it's just not seen like that by government. It's a highly distributed, not really national attitude around the workforce, which will get the wages high enough and get people working in this sector with a career pathway and a plan. Funding we all know, but I very much want to say, as Vic has said, the funding is at the wrong end. There's not enough in prevention, and there's a great opportunity with the NHS plans. The thing that makes me angriest is the potential of working with primary care using population health management, and yet we don't have the resources to do that work. And then finally, care markets. I think we feel in ADAS there is a regulatory issue, there's a quality issue that means that if we're going to invest in social care, we need to have that addressed. There's a real problem as well as a perceptual problem about the quality of care that people experience. Not enough control, not enough outstanding experiences compared with, say, the NHS or some other sectors. So those will be my opening challenges. Thank you.
Thank you, James. Certainly, we at the BMA, we thought it was extremely surprising that the proposals about integrated care systems fail to address social care or how ICSs will interact with it in the prospective role in ICSs. Morgan, Sheila, Danny, Ivan, special pleading to keep it brief, Ivan. Morgan, please.
Thanks, Helena. So just to bring in a few things, building on what James said, I think for many of the people we speak to, they see social care as a negative rather than something that can be really empowering and enabling. They see it as, oh gosh, that would be if I got to the last resort, then I might need help. So I think there definitely needs to be a narrative change in terms of how people view it, that it's something that can support independence and can enable them to carry on doing the things that they love. For those who contact Independent Age, we know that they just find the system incredibly difficult to navigate. When they are in a situation where they can't get out of bed or they can't get dressed easily, they've got no idea who to go to. They don't even know that there are people they can call to support them. They've got no idea there's a financial threshold. They don't understand why getting out of bed is any different to being in a hospital, for example, and they assume that some of it at least would be free. And obviously that does impact people in later life, as many do have savings. And we hear from people all the time who are so worried about running out of money and not having a cushion, which I appreciate is an extravagance which many can't afford, but for those that do, the fact that they're thinking of running down all their savings often means that they wait till crisis point, or the pressure on their unpaid carer family member can get really, really extreme. The other thing I just wanted to raise was around continuity of care. So many of the people that we speak to, and as others have said, this is about people getting care in their own home rather than necessarily in a care home. They tell us they can see 12 carers a week, and doing something really intimate like giving them a bath. It's difficult enough to process allowing one stranger to come in and give you a bath, let alone 12 in 1 week. So at Independent Age, we're really supportive of the workforce being better paid and being given support to develop and train and retain really brilliant people, so that the people on the receiving end of the care are getting somebody that can come to them regularly and they can build a relationship with. And I think that's really missing at the moment for lots of people.
Well, as a GP and our members, indeed, we couldn't agree with you more, I don't think, Morgan. Sheila, please.
Well, I have a question. Is it possible to talk at the same time, using the same words, care and support, about people who are ageing, where the aim is to retain independence and well-being for as long as possible, alongside the different aspirations for disabled adults of working age who are seeking to increase and sustain independence and well-being, if you like, where care aims to unlock their potential? And is it possible to talk at the same time about providers of care and unpaid family care? I'm very supportive of a skilled workforce with a career path. I did some work with Health Education England looking at this in terms of care roles needed for people with learning disabilities who were part of the Transforming Care programme. So many people with learning disability, autism, people with spinal injury, for example, they do need skilled workforce. But one concern is whether formalising care in this way might lead to an over-medicalisation of care and a loss of a focus on independence. So those are the kind of conundrums to me which seem really central.
Thank you for bringing that up. Danny, please.
I won't go over the ground that colleagues have covered. I suppose just to add something for those of us who work in the health service, there is a risk that when the social care is considered, and it's not considered enough, as we saw during the pandemic, that our frame of analysis is entirely through an NHS lens. So the success or failure of social care, the perceived success or failure of social care services is entirely defined through its impact on NHS services. And that leads to a bias towards our institutions and services, but leads to a failure to properly address many of the real needs of social care services and those they're trying to support. And I do think that's a challenge that's bedeviled policy in this country for a long time, and we have to be frank, it also affects the way in which sometimes, hopefully with the help of people like Vic and James and the missionary work they do with the health service, we're getting better, but it sometimes affects our local conversations as well.
Thank you. Ivan, and then Colin, you've got the next spot, and I'm going to ask you if you can to think from challenges into what's needed to address them, please. Ivan first.
Thank you, Chair. So as Chair of the Community Care Committee, we passionately believe in the Ethical Care Charter. Some of you may have heard of it. It's originally drawn up by Unison, but with Age UK and the Community Care Committee, we actually lobbied a few MPs at Portcullis House a couple of years ago to try and sort of expand this. And some of this data is from Age UK, in that 30 to 40% of the carers that are working in the community have no idea about medication administration or about falls management and so on and so forth. These are really, really important issues that affect and impact not only the elderly, but also the young and the disabled. And so I'm sure you've all watched 15 Minutes of Care by Claire Sweeney, which is really, really sad when you watch it. And earlier, I think, Morgan, you touched on the fact that people coming in, washing you and all that, and 15 minutes of care like that, to the most vulnerable, to the most needy people in our society, in the first world, is just deplorable. So my plea is, and the Ethical Care Charter clearly states, is we want to have a living wage for our carers, but not only just a wage, but we need to have a proper pension scheme, a proper appraisal scheme, a proper learning and mentoring scheme that should run with it. So they are valued. The carers are looking after our most elderly and vulnerable and disabled patients, and we need to value them. We need to give them a place of belonging and also importance, which I think is lost in this whole system. Thank you. I hope I was brief enough.
That's great. You led, Ivan, for me just to say before Colin chips in that a graduate carer messaged me last week to say that this young woman graduate carer is either being asked to change in her car between visits to people's homes or wear the same PPE. And I'm sorry to say that when I asked for an update on this situation yesterday, she told me that, not unsurprisingly, she now has COVID and took COVID back to her family, including vulnerable members from the BAME community. Colin.
Thank you. You asked me to sort of segue to the next bit, and I suppose what I think is initially needed is some level-headedness. I think we're about to see, and it has been picked up by other speakers, that as we enter the post-COVID period, hopefully we eventually enter the post-COVID period, I think when they start to analyse it, I think there's going to be huge concern about the rate of death in care homes. And the danger is that this results in a very knee-jerky reaction, significant increased legislation. Certainly, I know in Suffolk, I think there's a lot of smaller independent care home providers who are extremely concerned of what might come next. And that could well result in a lot of them exiting because they simply cannot afford, they cannot comply with what is going to be required. So I think there is a danger that the whole agenda is hijacked very early on around this particular issue. You know, it's very definable. Death is a very transactional thing in some ways. You know, people will look at this and say something has to be done. And I think it is really important that those messages around prevention really come to the fore, that what we're actually about here is how we shape a society that doesn't just arrive at a certain point of need and the only offer is a care home, whether that be frail or dementia, but your only offer is a care home. And I think there needs to be a conversation around what social care is in our communities, who delivers it in the communities. And I agree with Baroness Holdings that you've got this issue also of younger people, which I think get completely lost. I think everybody just deals with older people, and the notion of a sort of working age population of people who have needs is just, I've been around this for 14 years now, and that has just been completely lost. And I think that the need for those conversations to talk about what it is to look after an older population, an increasing older population, has to come through, because there is this danger of hijack. The only other thing I just wanted to particularly pick up on was this 15 minutes of care, because that's where I started. I literally sat on a working party on a scrutiny committee, and we had 15 minutes of care in the mornings, and I said, I can't get out of bed, get dressed in 15 minutes. What are we doing here? And we changed it. But all the time, this costs money. And at the heart of all of this is money. The Open University produced a report which backs up this point of a living wage and career progression last week. And you look at the sort of the comments you've got in your headline in the paper about the 12 million, the increased cost to actually make it something that is a career. This is all going to cost substantial sums of money. So for all the conversations around COVID and care homes, the fundamental one here is money. And how are you going to pay for a system? Because the danger from, I think, upper tier local authorities, and I'm sure James will agree, is that you just each year see the percentage of the budget, and it's called the graph of doom and various other things, but you just see, and it doesn't take a genius to look at your aging population, look at the percentages within your population and see where the money is going in adult social care. So fundamentally, this is a discussion about money and how we're going to pay for a better system. Thank you.
Thank you, Colin. Yes, and thank you for segueing and raising money as a fundamental issue. I've got Una and then Caroline, please.
So I think for me, the issue that I find is that we can find it hard to get to the next level of detail and work out where we think we need to start. And I feel like I have a lot of conversations around the challenges, and I feel like there's a bit more detailed work around the so what, so that we can say this is where we need to start. So yes, I think we definitely need a sustainable funding model which allows us to have the right level of support to meet unmet need, but also to have a valued workforce. And within that, it's really clear that we need career pathways. We need to value people who work in social care, so that we get more people working in social care with the right values, but also that they stay. We've got real issues with well-being, and in 15 years, we are predicted to need an extra 500,000 people working in social care, and that's building on a gap which is already about 112,000 vacancies a day. And so that gap between supply and demand is, that's not a problem in 15 years, that's a problem now. And so I think that ultimately, I think we do need to be thinking long term. We need a workforce strategy and a social care strategy, but we also need to know where we're starting, and we need a vision for where we're ending that starts from the needs of people accessing social care. Because while we definitely need to start with funding, I wouldn't want us to end with funding and think that's it solved, and it just feels like the more we can get to that next level of detail, rather than feeling so overwhelmed by the fact that there's so much wrong that we just don't know where to start.
Yeah, thank you. Caroline, please. Caroline, I think you're the first one of the morning.
Sorry, I've committed the sin. I was so keen to remove my hand, I forgot to unmute. Yes, I wanted to follow up a bit on a couple of things other people have said, and think about the impacts of the pandemic. So I think where we're heading is probably, as you say, a lot of people who've noticed anything about care will have noticed it's about care homes. But I think there'll be a move away from care homes as a result of the pandemic, in the sense that there'll be some loss of confidence from the public. So I think that's an issue, and that maybe isn't necessarily a bad thing, because at the moment I think part of the problem we've got is that there aren't enough intermediaries between staying at home on the one hand and being in a large residential setting in particular on the other. And I think there are some newer, more interesting models emerging abroad of much smaller settings, which of course you can't get the economies of scale in, but nonetheless, and home care definitely needs a boost, and I think living care will get a boost as well. I think all those things are simply inevitable. But I think one of the other lessons of the pandemic, given it's the BMA hosting this, is that the links between health and care aren't what they should be. Sometimes they've worked brilliantly. There've been some fantastic local practice. There's been lots more to worry about. So far as care homes are concerned, the Enhanced Healthcare in Care Homes initiative, I think, is welcome, but I don't think it goes far enough. And I think that the jury's out really as to where we go after this, and whether the ICS proposals, which are still very skeletal, I think, as far as what's in the public domain anyway, are whether they're going to do enough to bring people together. I mean, one thing certainly we would like to see at Age UK, and I think this is true for the CSA too more broadly, is a commitment from government to move to parity of esteem for people who do care jobs across the NHS and social care. That's a big shift. It has a big financial implication. But for as long as basically the NHS uses social care as a kind of nursery to pluck people out of to fulfil its own workforce shortages, which I don't blame it for, because there's no disincentive for it not to at the moment, but that's simply robbing Peter to pay Paul. And people are doing the same job, but for very different rates of pay and inferior terms and conditions. I don't think we could do it straight away, but I think a commitment to move to that over, say, 3 to 5 years would be very grown up and would help bring people together. And I think the future for lots of older people with profound needs, obviously the people we worry about the most at Age UK, is a much more joined up health and care offer in care homes, in residential settings, and in their own homes too.
Thank you, Caroline. And just because I heard Colin talking about not hijacking through this absolute measurement of death, of course, as a doctor and speaking for the BMA, the impact of the pandemic in people with pre-existing disease surely means that we need to invest in population health measures to address chronic morbidities, or obesity, diabetes, air pollution, all those things that will increase people's likelihood of needing social care to make this really sustainable. I have Emily next, please.
Thank you, Helena. I wanted to bring up a challenge in that I think the pandemic has masked some of the issues, as well as in relation to the paid care sector, in that we and our friends across MenCap and National Autistic Society and Alzheimer's Society have all found that the needs of people needing care have increased. And unpaid carers, as you know, have refused services. About 1 in 5 have refused services. A hospital discharge situation is completely different, because people are so worried that we've actually masked need. So we would say that the baseline of social care need has increased because people's needs have increased. You know, learning disability and challenging behaviour at home, routines destroyed. We've seen people lose speech. All sorts of different daily, really important things in their lives. So we need to recognise that baseline has shifted, and perhaps Charles might like to come in on that, and James a bit later. The second thing is that carers have sort of had to soak this up, if you like, partially by their own decision, but also about a shortage of care. So when we come out of the pandemic, we will see a completely different dynamic. We have had furlough, so it's allowed people to not work and provide care. And of course, that will go. And people will have to return to work. Unemployment, is on the rise, but still businesses and employers will need people across all age groups to juggle work and care, not least the health service, which could have up to 1 in 5 people who are juggling work and care, about 250,000 people. So I think what it's done is sort of mask some of the demand issues, which I think will increase when we come out of this. And that, of course, as GPs, you'll know all too well, you'll see that in your surgeries because people haven't been able to come because of access, but also because they can't get the care to come. So I would like to make sure that in the short and medium term, we build in those answers. I agree with my friend Caroline about the ICS systems and legislation. What I think we need to do is pull in more social care and pull in recognition of carers by the NHS as well. I think it's something we talked about, a long time, Helena, haven't we, about the NHS really understanding the role of carers, unpaid carers and family. And that could be a landmark way forward. Just a principle would be a landmark way forward.
Thank you, Emily. Just before we move on to perhaps building on Caroline's collaborative type move that we might come to together even this morning, I just wonder particularly whether on funding we might perhaps hear from either Simon at the King's Fund or Andrew Dilnott just before we move on from funding. We're here to Andrew. Thank you.
So I feel a bit like a stuck record, so excuse me for this. And I'm going to have to leave at about 11:30. So I'll on funding. I think there are 2 quite distinct challenges. The first and the most urgent is we simply don't spend enough money through the state on the means-tested social care system for either adults of working age or for older adults, and it's critical. It's absolutely critical, and the current levels of spending are wholly inadequate. So I think that the first and pressing thing, which the Treasury has sort of grudgingly accepted 1 year at a time, but not quite accepted. So for most of the last 4 or 5 years, there's been just enough money, extra money put in to stop the whole system completely falling apart. But the pressure that people are working under, the levels of eligibility, the 50, all of that. So on funding, critically, for those who don't have resources of their own, we're not spending enough to look after them in a way that a civilized society would expect. And that's very, very bad and needs to be addressed. Then there's the second challenge, which is why should the wider population have any support? And the simplest way I think of putting that is the thing that I've gone on about again and again. It's easy when we're talking about social care to imagine that everybody will need a lot of social care. And the truth is that most of us won't need a lot of social care, but some of us will need a huge amount of social care when we're older, and we've no way of telling who that's going to be. And the structure that we have at the moment essentially says to people, treat this as something you have to save up enough. And I think it was Morgan who made the point that most people couldn't possibly save enough to protect themselves if they ended up being somebody with high social care need. So we have to tackle that. The simplest way of tackling that would be to move from the current structure to an NHS type model. So just to nationalise the whole lot. That would be much the simplest thing to happen. I don't think there's any chance of that happening in the near term, but I don't think we should pretend that it's not feasible. Could be feasible, it just would mean a level of tax increase that I think politicians on all sides will run away from. If we're not going to do that, if we continue with an essentially private sector model for the provision of most care and the paying for an awful lot of it, then we have to find a way of allowing people to pool the catastrophic risk so that they're not faced by the terror that Morgan and others have described. And in my own view, that's a critical part of dealing with many of the other things that matter desperately: workforce pay, workforce esteem, workforce supply. Because if we still rely on self-funders funding themselves, then unless we take away the catastrophic risk for them, they will continue to try to buy the cheapest care they can possibly get. And that's what drives wages and conditions and esteem down. So on funding, we've got to spend more. We will be spending more. We have to produce a structure in which we can spend more sensibly. That probably means that there are going to have to be some increases in taxation to pay for this and other matters. And I think as a sector, we have to recognise that and say that we can support that, but if and only if what's offered by government in return for people paying more is something that people might actually be willing to think was better. And then the final thing I wanted to say, turning to the thing at the very end, which is priorities for social care reform. So of course I'd have those two funding things, doing something for the means tested system now, doing something for the population as a whole as two of my three. The third, and this goes back to what Baroness Hollins and others have said, is something that when we did the work on the Commission 10 years ago was for us central, was producing a structure, a way of thinking about this that allowed us to think about people of working age in the same breath as thinking about those beyond retirement age. And I think one of the worst things about much of the political debate in the last 5 years is we've moved away from seeing that we have to have a way of thinking about the dignity, independence and quality of life of the whole population in a coherent way. And so I think I put as my third priority making sure that we don't, as we all too often do, allow working age adults to drift out of the conversation, and make sure we have a structure, a way of thinking about it, a public policy framework that treats everybody not necessarily in the same way, because actually I think those of working age who have significant care needs should be treated in a sense. We shouldn't expect those of working age who have care needs to have prepared for it themselves. Not unreasonable to say to somebody who acquires a care need in his 80s that some of his working life might have been about preparing for some of those costs. That's not a reasonable thing to say to somebody who reaches adulthood with an already established care need. I'm sorry, I've gone on much too long.
Not at all, Andrew. I think what may have changed, of course, is now we have a lot more discussion about intergenerational issues between the under 40s and the boomer group, and it might be interesting to hear perhaps from you in writing as a follow-up how you might think of us addressing that particular issue that's more new than it was 10 years ago. I've got Vic and Colin, who segued so well last time, and Ivan, please.
Thank you. Yes, and I want to push on to talk about integration, which is good because that's what I was hoping to pick up on that point. So I think there's a couple of things that again we're sort of, maybe some of the kind of COVID positives in a way. So one of them that Caroline's already mentioned is the enhanced health and care homes, which I know is just very care home focused, but is about a sort of new contractual arrangement and a new focus around having that kind of clinical leadership in place within homes. And I think at the moment the experience on the ground is that is very led almost by personalities rather than by policy in a sense. So established relationships that work well continue to work well, and I think we've got to get a lot better at a kind of shared understanding of what that will mean in practice. What we've got as a result of COVID is a much stronger data set around social care, and I think that's a new thing that actually we need to think about how that gets used for the broader community kind of understanding of social care. It's a data set that's growing in its richness, it's growing in its burden at the same time, but it's growing in its richness too, and will tell us lots about social care in real time in a way that we haven't been able to do so before. So that an opportunity to kind of match up and read across between health and care data that hasn't been there before, which we should think about how that could be used. I think the other points that have been made about ICS, the current proposals are very thin on social care involvement. And one of the challenges that we have and need to think about how he addresses that regional or ICS level kind of representation of social care provision, which doesn't exist in the same way. Yes, there's local authorities there as a kind of way in, but that isn't the same as having provider representation at that level. So that's something that would be helpful to explore. The point about new models is very important, and I think is a really important point for integration, because I think when we've talked about the care home model and home care model, they were developed almost in isolation of any connection with health. They were the alternative to health in a sense, and now actually almost everybody who's in receipt of care will be integrated in some way around health needs. So new models need to have that integration very much at their heart. And finally, the digital side of things is another win. There's been a significant shift forward in terms of digital integration between health and care. There are lessons to be learned, I think, from ways in which that integration has happened successfully, which has been much more effective when there's been shared goals, and it's not been a kind of pull from a case of kind of pulling social care to play catch up with NHS. So where there's been sort of opportunities for shared goals, shared input and respect across health and care expertise, that's been much more successful in terms of getting that digital integration moving forward.
Thank you. I've then got Ivan. I'll just point out James's comment is very interesting that you have just made on the side, this common causality between housing and health and care and community sectors might be one of the things that we can be thinking about, whether we agree. Ivan, please.
So, thank you, Chair. So I'll be brief. So one of my other conflicts of interest is I'm standing as a local councillor, as a Conservative councillor in Wirral, and therefore I'm quite au fait with what's happening at the local council level. And one of the big questions that Colin's raised, it comes up time and time again, is around value for money, and how can we make it work? Social care costs so much. But my answer, and I'm only a simple GP, is this, that, I have a patient, and I can give you many examples of this, who spent 5 months in hospital because they could not arrange for that patient to be looked after in the community. And I can argue, and I have argued with the hospital, that we can provide the care in the community at a fraction of the price if we had the right number of carers who are qualified, who are supported, and who work in an integrated health and social care system that we are all talking about, which has a single operating system, a single IT system where people can look at what the carers have done, what I have done, what the district nurses or the community nurses have done, or what the Macmillan nurses have done. And if we had that model where the care in an acute trust is only acute, and chronic care is not provided in the hospital but in an intermediate or in a community setting, the value for money would almost invariably come into social care. And then we would realize how important social care is and how importantly it glues the acute and primary care together. Thank you.
Thank you, Ivan. And just to remind everyone, the BMA, of course, is not politically aligned with a single party. I just wonder, one of the things that members are really concerned about, and perhaps moves into points people made about how the social care is currently a nursery providing members of staff for the NHS, is the 0-hour contracts, the lack of training. And I wonder whether I'd very much like to hear some of the attendees who haven't spoken yet, and I didn't know whether perhaps we might hear from I don't know, as anyone that's been keeping quiet as we move into the solutions for the short, the medium term, and perhaps some things that we might call for together. Simon, thank you.
Yeah, I'll move on from funding, about which there's quite a lot to be said. But when we start to look at solutions, I think one of the things we ought to be, and we've talked about new care models rightly, but we also need to think about existing care models. And you look at the Care Act 2014, there was a huge emphasis on personalisation and the rollout of direct payments and personal budgets so that people had choice and control over the care that they received. But when you look at the markers of that, you see massive local variation. So in some local authorities, you'll find half of people use a direct payment to purchase and commission their own care, and in some places it's only 1 in 10 people are able to do that. And that reflects a few things, but I think overwhelmingly it reflects culture and individual local authorities. It's not simply about the number who get direct payments. It's also about the degree of policing over them. But nonetheless, there's a huge amount of variation. So yes, we're going to need more money. I think it's absolutely clear that we need more cash. However, we also need to think about the culture of the social care that we deliver, and a huge chunk of that has to be continuing to or accelerating the speed at which we personalise care. And when you look at direct payments, they've essentially stalled. There are fewer people, I think, last year using direct payments than the year before. So unless we address that fundamental culture issue, we risk just putting a lot and lots more money into a system which has some basic problems at the heart of it, I think.
Thank you. I've got Chrissy and Colin and Sheila. I'm looking at you taking some notes. It might be good to hear your view, perhaps afterwards. Thank you.
Thank you, Helena, and thank you all. It's so wonderful to be in a room, in a virtual room with so many people where there's so much agreement despite the complexity and the enormity of the problem. As I agree with everything that has been said, and if I could just make a plea as we move towards thinking of solutions, that we embed considerations of health and social equity into those solutions. And particularly when we're thinking about digital solutions, over 50% of people on low incomes of around £6,000 to £10,000 don't have access to digital means. So also, if I may, in addition, just add from a patient perspective that the one constant regarding the provision of social care, regardless of condition or the support needed or where in the country it's been implemented, is the person or the patient. And often planning around social care, and I understand the need for this, but it tends to be top down and focused on aligning budget and sharing resources and based on vertical or horizontal integration. And whilst these are an important part of the solution, the measure of success of any system is the effect on the person. And that requires consideration of individual need. So that's my plea as we move forward to solutions. But I just want to thank you for the wonderful quality and depth of this discussion. It's really uplifting. Thank you, Helena.
Thank you, Chrissy. Colin and then Sheila, please.
It's always a bit of a challenge when the very last things you have quality and depth, and you hope your comments will be precisely that. Just a couple of things, and I think around this sort of policy issue, I completely agree with Andrew that, you know, when we look at the level of funding that is being talked about here to bring parity, to make it free at the point of use, I can't see it. I can't see politicians applying that level of tax increase. The danger for local government is one of the ways in which we seem to be funding social care at the moment is council tax, which is a very regressive tax. And I think for those that are in that hinterland between those that don't really think much about council tax and those that are supported so they don't pay it, I think there's a huge number of very hard-pressed people who are really starting to struggle with a 3 to 5% per annum increase. But I do think, and Andrew will be a veteran of this as well, you know, when we were talking about this before, the insurance industry started to think about it, and Naomi and Nye, who were sort of going around the system and talking about how they could create product. I do think there is definitely a space there that you have a huge financial set of investors looking at this sector, and there is no product. And that is really unusual, that there is no product, because of the open-end nature of the commitment and the difficulty in how they can actually monetize it. But it is unusual that most sectors in life, there is a huge amount of money floating around, there is a huge amount of product, there is a huge amount of interest, and at the moment we don't have that in this sector. I couldn't represent the LGA without talking about integrated care systems, and our concerns with ICSs, that they are still very NHS focused, and there is within that a lack of representation of providers, there is a lack of representation of service users, and there is a lack of understanding of what community is. And my single biggest comment here would be the one that Ivan was making. I've been around this for so long, and I've heard so much about how much it costs to hold somebody in a hospital bed and how much cheaper it would be to put them into an intermediate bed, and we still don't do it. We still don't have them in the scale, and it just absolutely staggers me that we haven't moved there. And I think there is, in terms of policy, not only this point about financial models so that people can insure, you know, I insure my car, I insure my house, I insure my life. Why can I not insure my care needs? This seems wrong. But also around policy around housing and intermediate care beds, and I think also around extra care and how you can use policy to drive forward. If we have this significantly aging population, why are we not making significant efforts to build extra care, so that at social tenure and at private tenures, we are not helping people get themselves to the settings at an aspirational level that allows us to take some pressure off the system as well. And that's, I think, where the policy end of this comes in. I think there's a lot of key policies that could be driven to make some of this happen. Thank you.
Oh, Colin, thank you for those really valuable points. I suspect Andrew might have a couple of answers about insurance and building, but he may or may not be here still to be able to answer that. Chrissy, thank you for bringing it back to individuals. Of course, we wouldn't be here unless we said individual and their carer. And David, somebody talked about culture, so perhaps after Sheila and Morgan, you might like to talk about culture, I don't know, or something else. Sheila, please.
Thank you. Well, I want to pick up on two things. I want to think a little bit about kind of integration, maybe in a slightly different way, but also about what we've learned through COVID. And I'm doing some work for the Department of Health and Social Care at the moment with respect to people with who are perceived as having very particular needs, who are being detained in long-term segregation under the Mental Health Act, and just how difficult it is to see them having a new and safe and more ordinary life in the community. And one of the big difficulties is the inability of shared risk across health and social care and all the different agencies that are involved. Okay, so that's one point, but I wanted to think a little bit about what maybe people are going to hope care would provide, or care and support would provide for them in the future post-COVID, because I think people's attitudes will have changed. Lots of people will think twice about moving into a congregate setting. This will apply not just to older people, but also to, for example, people with learning disabilities. The risk is very similar. The risk of catching COVID in a care home, residential setting, or indeed supported living settings for people with learning disabilities has led to as many deaths as for older people, and yet it's not been noticed and observed. Okay, and of course there's an issue there about the lack of the prioritisation for people with learning disabilities. 2 out of 5 will reach the age of 65, but the emphasis is for the vaccination programme is entirely or mainly age-related, and fails to recognise that some of the really deeply ingrained inequalities, health inequalities that have existed for ages for people with learning disabilities. So that's one thing. I think focusing on what matters it's actually people have realised that it's relationships that matter, not just family relationships, but relationships with friends. You know, I have a relative family member, an older person with dementia who died during the pandemic. The pain of not being able to visit him in his care home, extraordinary pain. But alongside that, the pain of people with learning disabilities in romantic relationships who haven't been able to meet since last March, who've not been able to meet because of the risk of infection is, of course, a priority, but the attention to loneliness and mental health and well-being is secondary. And then finally, I would just say the role of home and family and the priorities for home and family have changed. More people are going to work at home, they're going to continue to work at home, they're going to continue to want to support each other, and the role of technology becomes really important. And so the keeping in touch through technology is vital. School children were getting iPads. People with learning disabilities at home weren't. Why not? Everybody needs to have a way to keep in touch. And I think that changes the conversation about care and support. And we need to catch up. Thank you.
Thank you, Sheila. And James, I didn't know that we only have 1/10 of the provision of extra care than the USA and Australia. That's a new one for me to ponder. I've got Charles and then Morgan, please.
Yeah, thank you. So I kind of made this point in the chat in a very abbreviated form. So I think I've been thinking about a lot of the kind of issues that, you know, there's lots of recurrent issues that people talk about around social care. And I think, you know, firstly, lots of these are linked. And secondly, I think when we're thinking about reform, we need to recognise that, you know, we do have a very mixed system. We've got private payers, we've got public people who are public supported, and obviously there's a very large number of people who are supported by unpaid carers. And that is likely to be a feature of a system going forward. So, you know, unless you make the whole system public, that is going to be a feature of the system. And even if you do make it public, informal unpaid care is still likely to be a feature of it. So there will be people who are kind of on their own or outside the state system. Often, and I'm not saying this is true in this debate, but I hear when people talking about social care, they're looking at it through the lens of the means tested system and seeing it through a local authority lens. But the reason that we care about social care isn't just because we pay for people. We should be caring about people because they've got needs and that we can help them with, either, you know, helping them make their own provision or providing care for them. And I don't think we should. I think we need to look at the solutions in a system. So, for example, workforce is something which people often talk about, and some of the times you get solutions which are, oh, we need to have local authorities need to write into their contracts minimum pay for people. But Andrew pointed out, you know, actually there are obviously workforce issues in the entirely private payer market as well. You know, there are quality of care issues. There are people getting, you know, short visits. It's not like pay is higher, pay is very low, even in people who exclusively work in the private, for private providers. These issues, therefore, kind of are systemic, and there are some root causes to these. And I would say, you know, for example, on that one, you know, lots of this is because the private market is not working. And the part of the reason the private market is not working could well be to do with some regulatory issues and information to people about the kind of quality of care they'll get. It's very, very difficult. It's not, many of the ingredients with well-functioning markets aren't there. But I also do think the issue about empowering people who are currently paying for their own care to understand their care journeys, give them more certainty. You know, the issue about the uncertainty of costs people face actually does not make for a kind of good market.
Thank you, Charles. And I suppose we just ought to point out, as the Doctors' Trade Union, that there are, of course, vacancies in healthcare as well, albeit far fewer, less of a problem. Morgan, please.
Thank you. Just reflecting on what others have said, I thought it was worth putting into the mix a group which I feel are often overlooked or not seen. To me, they're sometimes a bit invisible, and that's the self-funders. You know, we talk about the local authorities needing to bring in money through, you know, council tax and that not being enough, but that's not even touching on all of the people who have over £23,000, which I know for many people that's a huge amount of money, but a lot of the people we speak to have just about paid off a mortgage. They might have downsized their property to support a partner, for example, going from a 2-story to a bungalow. So they do have these savings and they are just left to get on with it. They pay for everything themselves. Often they don't, you know, Baroness Hollins was talking about the importance of maintaining social interaction and friendships. Many self-funders just don't feel they can justify that. They just pay for the bare basics that they need. We also speak to people in areas where if they do ask for help, once it's discovered that they've got over the 23,000, they're not even given information and advice on how to access care. So I appreciate that these people do have more choice than somebody with no money at all who's completely reliant on the local authority, but often they're in a really difficult position and missed out of kind of all of the stats when we think about budgets and how to bring the money in.
Thank you, Morgan. Now, I'm a little confused because I think there may be some legacy hands around. We touched on adults with learning disability and then people with mental health conditions, and we have lots of ideas and lots of agreement. I guess if the window of opportunity is in the autumn in the comprehensive spending review, what should we be asking the UK governments to do to address these issues? Right. Charles, is that a legacy hand, please? Oh, and Charles is on mute. Okay, I'll take Vic and then Ivan, please.
Thanks, Helena. I mean, I agree that the spending review is a kind of key focus. I think the big problem we've got, and people have mentioned it a number of times, is going back to this idea around vision. And I think while it's really hard to, within that time frame, get us to a place of vision, I think we've talked a lot around it in this conversation around that integration and around the workforce agenda and around you know, bringing prevention higher up the political agenda. So I think it's important to talk about the money bit in the spending review context, but I'm really worried that once again we kind of fall into that trap of money being the only part of the solution, because it's actually about, you know, coming back to that sort of central role that care, prevention, support plays, which is about giving people the best life that they possibly have. And I mean, I go back to Baroness Hollins' sort of first point, can we have the same conversation about working adults as older people? I think we can, but I think only if every conversation about social care starts with, you know, whatever's being delivered, however it's being delivered, is this making a difference to people's ability to live as independently as possible? And I think, you know, we've lost sight of that so far from all of our discussions in many ways, that unless we can find a way to articulate funding that fulfills that, then we run the risk of, you know, coming up with a figure that we need put into the review, and that then dictates the way in which care gets delivered in the future. So it's not a solution, I'm afraid, but I just think it's a point of principle to keep coming back to.
I think that's very helpful, Vic. And when I asked about what we could jointly ask the governments, of course, we've also spent a little bit of time talking about the current English ICSs. And you know, I certainly, the BMA are concerned that local authorities and social care wasn't raised in there. And if we're focusing quite rightly on individuals being independent, and indeed carers of individuals wanting that independence for the individual, there's prevention before the need for it as well for the independence. And there was some talk about prevention earlier. Ivan, and then I've got a hand up from James, please.
Thank you, Chair. So I'm only a simple GP, and I think what Andrew said is quite visionary, and I'm sure you're all visionaries. And for me, it resonates a lot. So, you know, the general practice bit of the NHS costs the total annual budget around 8% of all we do. So 90% of all consultations done in the NHS are done in primary care and general practice. And for that, we only get 8% of the total budget, which is in excess of 130 billion. So here's my point. My point is nursing homes, residential homes, carer organizations are all struggling financially. Okay, general practice are independent practitioners that are being contracted to provide for the NHS. So Andrew, and you're all bright and intelligent and much more than I am, could we not have a model where the nursing homes, the residential homes and the carers organizations could be incorporated into NHS family, and funding for them would still be coming through in some sort of a format, through the NHS. I mean, I'm sure you'll all shoot me down, but is that possible? Thank you.
Well, that's a great challenge, Ivan. I've got James, Sheila, and Danny, please.
Thank you. I don't know the answer to Ivan's question. I think it's worth answering actually as well. But I suppose in terms of asks, I would say there's a certain amount of fixing that we need to do now to stop the system from falling over. I think we've had a year of one-off investment, which has been absolutely necessary. I wouldn't criticise government for what it's needed to do during COVID. But I think next year and the next 2 years, before we get to a reform implementation, there are significant dangers which need to be picked up. So and that includes formal social care, self-funders, and carers, that fixing thing. I think my second ask would be to stay local. So do not, as it were, fall for the temptation of centralising and nationalising. Could nationalise the funding or whatever, but stay local, let local areas, local authorities, local health services, local community sector and providers plan together. Because I think that level of work is absolutely necessary to do the targeted work. And I think, to echo something that Vic Rayner said earlier, collect more data. There's just a simple amount of national ignorance about what social care is and how many people are affected because we don't bring the data together. And then finally, government need to assure itself that its investment will go to where it thinks it will go to. And I think that inevitably has been a lesson for COVID. Government doesn't know enough about what local authorities do, and they need to pick up that point in a fair way that is not too burdensome. Thank you.
Thank you, James. Sheila, did you want to come back before Danny, please?
Okay, well, just to say a few things about what I think priorities might be. It would be, to me, a well-funded, trained workforce. I don't want to see something that is too much based on safety and risk, but they obviously have to be thought about. Choice and personal priorities really matter. I really think community development is important. And one of the difficulties in the areas that I'm concerned about is that actually every person is different. Everybody's needs are different. Sometimes they're quite complicated. And what I've been seeing quite a lot of is how unskilled commissioners are. When you come down to thinking about people who are in minority groups, who actually, I mean, they aren't a group, they are an individual with very complex individual needs. Commissioners are making quite a lot of mistakes. So there's an issue about how to develop local commissioning capacity so that care for individuals, care and support for individuals really does have a chance of meeting their needs, and must include quite a focus on prevention. And right the way through all of this, to me, one of the biggest priorities has to be attending to people's mental health and well-being. And that's for people's carers, support workers, support staff as well. So you see, the trouble is there isn't just a headline answer to this. And if there is a headline answer, then it's going to miss the point. That to me is the real challenge.
Thank you, Sheila. Yeah, and just before I go to Danny and James, when you were talking about this year's one-off funding, I would be interested in yours and other people's views as to whether the Infection Control Fund reached the ground and made a positive impact. But I don't want to divert us. It's one we could answer out with this roundtable. Danny, please.
It's to reinforce some points. I mean, the point about how the legislation and the implementation of that legislation encompasses the partnerships we're seeing in the best ICSs is one our members would violently endorse and was a central plank of our feedback. There is a sense that the national conversation about ICSs has been too preoccupied with NHS architecture and frankly hasn't kept pace with what our respective members and colleagues are doing in reality. The point about local is best, having worked in the National Health Service now for 30 years, and arguably it's at its most peak national now, the National Health Service. We know that actually that need to invest in local relationships to build local capacity and capability is hugely important. So I would strike a similar note of caution, Ivan, in terms of our experience in the NHS, probably having some lessons in terms of how not to do things as well as how to do things. And I do absolutely agree with the point about both addressing the medium term and the immediate term, and needing a vision. But we can't duck the fact that that vision does mean money. It does mean changing the way in which we ask the population as a whole to contribute towards funding social care. And the reason we're still talking about Andrew's work 10 years on is that politicians of all shapes and sizes recognise the importance of the question, but are happiest taking lumps out of each other when the other side tries to address the issue. And we need to find a way of asking all politicians of the various parties across the four nations to actually accept that something does have to be done. And for the present government, appreciate that we need to give them a pass because their first year has been disrupted, but they do need to do something with that majority that they've got. And there weren't that many commitments in their manifesto, and one of them was to fix social care. And I think there's something about the pressure that we all collectively exert upon them to do that. And fixing it isn't just about money, and it definitely isn't about some annual kind of cycle of short-term investment. It is about a long-term plan. It is about a long-term vision. But they've got a couple of years before they have to start to think about the next election to do that. And I think we need to be ruthless with them across health and social care in terms of applying that pressure on them.
Thank you. So we've got something immediate about extending the things that we've seen in the last year. I think we've got a feel for something medium, and then we've got this long-term vision, including prevention. How do we best support each other to do this? Oh, I think Andrew, you're just about to go. Did you want to have a last word, or should we say goodbye?
Just to say thank you. I found this really encouraging and as I say, enlightening. I think there's, I think holding together that money is essential to sort this out, but nobody is cared for by money. I mean, I think we don't use pound notes to look after people. We use people, and it's people who are being looked after. But we just have to get this done. It's a tragedy that we haven't done more on this, and so I think we have to use our voices over this coming 6 months to push for action. And I think if we do, we have a real chance.
Thank you.
Sorry to have to go.
That's all right. Just get this done. I think it's a good going out message. Thank you very much for coming, Andrew. So other messages building on the we just have to get this done one, please, for how we can progress on our very many shared expressions this morning so far. Sheila, please.
we have to get something done. The question is, I don't see there's a single solution. I think that's my problem. And so it's got to be, we certainly need more money in the system, but we also need to have a bit more clarity about how that money is going to be spent and what it's being spent on. And I think, you know, great if there is a vision for prevention, but I actually think training the workforce and giving people career progression and valuing and making a distinction between people who are new and people who are senior. And also in work that I've done previously, it seemed to me to be quite important that there was the possibility of a crossover, so that sometimes people with nursing qualifications or occupational therapy qualifications might find that they have a really key role in direct care in the community, but the terms of employment are just not advantageous. So I think, you know, there has to be a structure and just throwing money at it without actually being very clear that we're wanting to respect and develop I mean, I know some disabled people would disagree with me that they wouldn't want to see a professionalisation of care, but I actually think that some of the extraordinary carers that I know and worked with, to give them the value and status of care as a better value for that would really, really matter. You know, I think that's.
Thank you, Sheila. So as the chair of the representative body, I hold up the policy that is made by our members on the ground, and our members on the ground have very clearly told us that they also want to see an improvement in the terms and conditions of employed carers that would be equivalent to what we see for NHS workers. We have absolute clarity in that policy in supporting that. I've got Vic, please.
Thanks very much. I mean, I just agree really with Sheila about that. I think that is probably one of the more straightforward ways to drive that reform agenda at this moment, in the absence of that kind of, you know, vision document that the Green Paper or other initiatives would have provided us with, is that actually if we can be really clear that what we want and what we need is a professional, I would say definitely a regulated workforce. We are really, and the training and the education and the development of that workforce leads us so strongly towards the delivery of care being around, providing that independence for people, for working through a preventative agenda to enable people to do as much as they can for themselves and to uphold those values around care, then that will be one of the most significant drivers of change within the sector. Social care is all about people. There is very little that sits outside of social, you know, that sits within social care that isn't either about the people who receive care or the people who deliver care. It is not that the expenses that are associated with it are predominantly about people as well. So if we're really clear about the workforce that we need and about how we need them to be paid, treated, what we expect them to do, what values we expect them to uphold, and how we expect to regulate them if they don't do that, then I think we will move mountains in terms of what we're then able to sit and talk about in 5 to 10 years' time, about quality, about models of care, about enhancements in terms of people's experience of care. And I think that should be a really strong joint focus.
Thank you for that, Vic. And just Una's chatting in the sidebar, but Una might be interested to hear from Skills for Care regarding the workforce development and training, or perhaps James on regulation, please.
Yeah, so being relatively new in post, it does feel to me like there is much more of a consensus around workforce, and so when I talk about getting to that next level of detail beyond the we need to do something around workforce, it feels like there is more alignment around that than maybe some other areas. So that real sense of needing to get our shared societal view, I suppose, of the workforce, the balance between general and specialist skills, and how that's going to develop, and how we get people people into social care, but also how do we help people feel valued so that they're staying in social care. And it feels like that, as Vic said, we're a people business. You know, we're people. This is all about. It's all about people. It's all about individuals. It's all about relationships. And so I think the more that we can get some clarity on, well, where would we start? What would that mean? What would the impact of that be? I think that could be a real driver, I think, for change, but also quite a tangible ask with a lot of consensus around it, I think.
Thank you. And I've got James, and actually, of course, I was also thinking about David James when we were talking about regulation. James, please.
Yes, I'll do the non-regulation bit. I wonder whether we should push. I think government currently are in more assurance mode than they are in more reform mode. I think they think there's still a piece of land to go through before they get to reform because of the noise and the chaos of COVID. But I wonder whether a tripartite approach should be pushed so that we give a message to government to say you can go into reform mode and look at what you did, look at what happened with ICSs and SDPs and the NHS plan, where you start with building this up. You know, you don't have a national recipe, you don't need one necessarily. You need to build up, but there are some things that need to be held centrally. So that's the first part of the tripartite. Secondly, to get ICSs as we develop them for 22, 23. Why not have a social care plan that's local within the ICS and local authorities and providers in the community sector? You know, I am a bureaucrat, so I do love a template, but I wonder whether that local work would complement the national reform agenda. And then thirdly, that workforce plan, you know, we do need to see this as an economic growth problem as well as a individual care problem. And it's such an opportunity to refashion some of our local economy and work with businesses and work with charities and so on. And I just wonder whether the third arm of that is a national workforce approach, again, led locally. So those three elements of reform, NHS and workforce could be the backbone of what we ask government to do. It would achieve probably 60%. None of it works without a funding solution. So there's something about that, but that's over there in a sense, and it's mathematicians and the Treasury becoming convinced. That's a political problem, which I won't comment on because I'm not a political body in ADAS.
Thank you. We've had some discussion at our representative body meetings regarding whether, in fact, social care should be nationalised and be absolutely much more like the NHS. I'm not sure if there's anyone that would like to comment on that at all. I sort of, Colin, maybe not on that. Colin and then David, please.
Well, I will comment on that, and I think, you know, there is a fundamental debate here, and particularly when we talk about free at point of access and not free at point of access. From the local government association's point of view, it is this, that when we look at prevention and when we look at the things that affect public health and when we look at community, these are the areas that are going to stop us needing to provide ever increasing levels of social care. If we are going in any way to address this, we have to have better housing solutions, better housing for some people, because COVID has pointed out there's an awful lot of people that have appalling housing, and there is a real need, and that is something that local government delivers through granting planning permissions, through shaping policies, through commissioning certain types of housing. So that's a really important aspect of it. And in terms of prevention, public health, as we've seen public health move across from the NHS to local government, I have been absolutely delighted the way in which public health has started to influence all the other aspects that go on. So leisure centres were once a drain. Now leisure centres are seen as places how you get your population moving, how you get them active, how you keep them active. Really, really important. And I think the danger of talking about social care moving across to the NHS, one is this slight clinicalisation of it. that it loses the sense of prevention, it loses the sense of public health, it loses the sense of how you create communities that support people that deal with social isolation. And instead of a community that deals with social isolation, it becomes some form of prescriptive service, which I think is a massive mistake. So I am a huge advocate of adult social care staying within local government, because all the other things that will deliver prevention, will deal with social isolation, will create the built environment that we want to handle an aging population. All those levers actually sit in local government rather than the NHS.
Thank you, Colin. Thank you very much, and for making that very clear. And you've got some agreement going on in the chat as well. I think we've then got David and then Caroline. Please forgive me if I got it the wrong way round.
Thanks, Helena. Just coming back on your invitation to kind of touch on regulation. From the CQC point of view, I guess I wouldn't really see us as having a role in regulating and registering the workforce, but I think there's probably something in how we regulate providers in terms of their ethical approach to workforce, how they support an ethical approach. That's probably something that we could do relatively easily. Obviously, working out the best way to do that. But going back to, I think to James's point about, and others have echoed the same point about the need to keep that local focus. I absolutely agree about. One of the things we found in our reviews of local systems was the extent to which local partners came together and had a kind of a coherent vision and approach to quality was absolutely crucial in delivering good outcomes. And I do wonder, and I made the point earlier on in the chat, but it might have been a bit of a convoluted way of setting it out. I do wonder if there's a conversation to be had about what is common to all of our concepts of quality. What is it we mean when we talk about good quality social care and good quality of life? And can we establish that shared area? But that's not to say that there won't be local focuses and local areas of priority. But I'm sure we'll have broadly the same idea of what we mean by good quality care. But actually, if we all went away now and wrote that down, we'd probably find some quite striking differences. So I do wonder if we can reach a greater consensus nationally on what we mean by high quality care.
Thank you. I think everyone here would clearly want high quality care, and it would be good if we can reach some sort of joint statements. I was beginning to think that, you know, short term, we've talked about social isolation, very, very important in COVID, and the COVID funding and the infection control and the PPE in social care. And then medium term, I think there's a lot of consensus about the national workforce, you know, an approach with the NHS rather than the NHS gaining from the social care workforce. So terms and conditions of service and training, and then I think prevention both in the medium and the long term. I have got hands up from I'm sure I missed someone, forgive me. I think Caroline.
Yeah, I think one of the things that the social care debate difficult is because it covers social care covers so many different sorts of activities for so many different individuals, and if you add it up all together, it is literally, you know, many millions of people. And Sheila, I think, has said twice during this discussion she's not sure whether it's possible to have, you know, to talk about everybody all at once, and I feel similarly. So just thinking about some of the older people that we at AGK worry about the most, people with you know, significant health needs and care needs, who may or may not be eligible for continuing healthcare funding, and who fight like dogs to get it, and or, you know, it's such a cliff edge. You either get CHC if you're lucky, or you fall a bit short, and you can end up you know, in a really bad place, having to fund large bills, and when you're dealing with people who are dying. And so I think there is a group of older people for whom it probably does make quite a lot of sense for their care needs to be dealt with much more by the NHS as part of a more integrated system, which you could do by expanding and making much fairer the CHC system. I completely see that's not right for everybody. And a word, of course, that we haven't used very much in this debate, I think it's been used once so far, is dementia. And of course, there are lots and lots of older people with dementia who in a way are the acid test, I think, one of the acid tests for any kind of reform agenda. At the moment, they're being quite badly let down by the care system. And in lots of different ways. We haven't got time to go into that today. But actually, ensuring that a system actually gives them the care they need without bankrupting them or their families, I think is one of the ways we need to think about reform going forward. And politically, that's going to make sense as well. We know that the dementia tax resonated very strongly at the last election. And, politicians need to learn from that. That's for a good reason. The public absolutely worries about dementia, and quite right too. Why wouldn't they? And we do need to resolve that. So I'm all for a bit of joined upness between health and care for a specific group of older people. Not for everybody. It wouldn't be right for everybody. So I'm probably in a slightly different place to quite a few people on this call. I quite like a bit of top down, but that doesn't mean we don't do bottom up as well. I think we need local initiatives to come within a firmer national framework.
Thank you, Caroline. That's one that I'm going to take away with me and have a think about, this idea that, maybe not joined up for everyone, because as a GP, I always think about joined up for everyone. And what I managed to achieve when I was both an elected councillor a couple of terms and a GP was so much more than only as a GP. So I will give that one a little bit of a thought personally. I've got Simon, please.
Yeah, on priorities, I hear what people are saying about workforce, and that has to be part of the solution. But it's worth saying that if we pay staff more, train them better, etc., it doesn't add one single extra person receiving adult social care. So that the fundamental reform, I think, has to be that we extend the number of people who have access to publicly funded adult social care. And broadly speaking, that's one of the things that Andrew Dilnot's reforms, which my guess would be is still the most likely significant reform we're likely to see over the next couple of years. And that's what the cap and floor model that Andrew was proposing did. So one of the challenges for us, I think, was that if we see some reform that looks like that, what's our response to it? And I think there are quite different views. We've agreed on virtually everything, haven't we? But actually, we would probably disagree about the extent to which we think a cap is important, for example. So having some honest discussions about where we see the priorities and what we're prepared to tolerate as a launch pad for a wider reform of social care, which includes, provider stability and includes the workforce. That seems to be, to me, to be where we've got to have the hard discussions, in addition to the discussions like this, where we're broadly finding consensus.
Yeah, thank you, Simon. I mean, for me as a GP, having done some investor fund locally, I think, well, a night in a hospital bed, which nobody wants, is £500, which would pay for at least 2 or 3 days in a care home, which would pay for a week being cared for at home. That sort of thing, that there is an economic argument for expanding the number of people with access to adult social care, even from a purely health point of view. Ivan, please.
Thank you, Chair. So a couple of things I wanted to raise. First of all, I think it's important. I mean, I know people talked about integrated care systems and partnerships. I actually like integrated care partnerships because I think this gives potential locally for place to develop and things to happen in a different way. So the local authority is where public health sits, but the local authority will be involved with the local CCG in its new format to develop, commission and provide services. So having social care as part of the NHS wider family or part of ICS doesn't medicalize it, but it incorporates it. And the second point that was made, which was around if we empower and train and make carers and people who are working in the community better, will not increase our work, output. I don't think that's right, because the Age UK data, which Caroline will be happy to sort of say if it's right or wrong, is that 30 to 40% of carers haven't had the right training. If we train them better, those patients won't be going into hospital. If we train them better, those patients or people, or whether they're elderly or young, will be better adapted to their communities and societies and be more happier where they are. And that is our big problem. Our hospitals are absolutely chock-a-block. They can't send anybody out. They can't admit anybody. We can't look after them in the community because we haven't got the carers, but we also don't have carers who have the skill set to do it. So we need to empower these carers. We need to give them tools that they can work with, and we need to support them to make this thing work. We can do it, but we need to believe in it. Thank you.
Thank you, Ivan. So I've got Emily next, and we have a very diverse audience, albeit we've had a lot of agreement this morning. I think that there's no way we can sit here and write a joint statement as we stand, but perhaps if I could ask everyone to offer a closing comment with something that they think perhaps the BMA has brought us together on this particular morning, that they would like or be prepared to write as a joint statement with the BMA. It may be that we've got some crossover, like a Venn diagram, that we at the BMA could potentially write back to you with this is what we understand that you might be prepared to have as a joint approach. So if I could perhaps ask Emily, with you starting, to also think about what Carers UK might write in a joint ask of the governments of what we should do next, either immediately, medium term or long term, from your point of view. Thank you.
Thank you. I suppose I'll roll my 2 points into one, and it was something I put in the chat that we'd really like to see a system that is clearer and more transparent, so people know their pathway through the system and they know what entitlements they're going to get. It's really, really difficult and complexity. It takes time and anxiety, and it actually helps the health and the social care system much more if everybody understands it. And James put some suggestions as well in the chat, but I think that also might be part of the top down that Caroline was potentially mentioning, so that we're all clear about what our journey is. And some things are more complicated than others, and the more complicated we make it, the harder it is for people to understand and engage with the system. I think I think going forward for us, our worry is that unpaid carers will be seen as a free resource, and of course it's not. It has enormous costs if we don't support unpaid carers, so we have to make sure that the system builds in the right kinds of support, and some of those are needed outside of the health and social care system, for example, within the benefits and rights bases that people have to take time off work, and that probably isn't for the BMA now. All of those things that have been discussed today, additional leverage of funds into social care that increases breaks, health and well-being. I think for us, the NHS and the integration agenda needs to have a little bit more consistency with social care. They're like two different systems really for carers and how they recognise carers. Politically, I think it's important we do make sure that we stretch the debate to all forms of social care, that we look at really the positive things that it brings to people's lives. So we would be very happy to look at supporting any joint statement, Helena, that you if you decide to go that way and put that together across health and social care. I think that would be that's quite helpful. But I'll leave it at that.
Thank you, Emily. And I've got Jonathan Ware, our Head of Health Policy, Public Health and Healthcare, with his hand up next. Jonathan, please.
Hopefully you can all hear me okay. So yeah, just a quick point as we get into this part of the discussion about what people feel they would be sort of wanting to call for in a joint statement. I think what Simon said a minute ago is correct, that you know, when you get into the detail of some of those things, particularly around funding, but also probably the other areas as well, there will inevitably be differences, and the consensus will not clearly extend to you know, a certain level of detail. But I just want to say, I think that I found the discussion so far really encouraging, in the sense that there does seem to be a huge amount of consensus around the big issues. And I think that it would be incredibly powerful if there was something that a group of organisations as cross-cutting as those on this call could say together, because it's, from my point of view, having sort of followed the debate around social care for many years, that's not something that you see very often. You tend to see social care saying something, local government saying something, NHS saying something. So, you know, I think even if it is inevitably a little high level, I think that there is just something powerful in people saying together, you know, we really need to do something about this, particularly in the light of the experience that we've had over the last year with the pandemic.
Thank you, Jonathan. We will focus on that. Danny, before you have to go, did you want to say anything? And thank you for coming. And then I've got Sheila and Colin. I think we might have lost Danny. Sheila, please.
Yes, I have to go in a moment as well, but I just wanted to say, I think what we need between health and social care is collaboration. And sometimes that form of that collaboration is actually some skills support of a preventative nature, or skilled interventions which prevent the social care placement breaking down. And this is what I see so clearly in the work I'm doing at the moment, chairing an oversight panel for the Department of Health, for people with learning disabilities and people with autism who are being admitted to hospital. And it happens because of a failure of social care. And I don't think the blame can all be placed at the door of social care, but rather a failure of the right help being and the right skill and understanding being put at the service of people and those who are supporting them, so that they can remain in their home and remain there. And reviewing 77 people's situations over the last year, it's been so disappointing to see how it's been a failure in the community of a collaboration and of a skill collaboration. So I think it's taking it down to a detail of a particular minority who are perceived as being very difficult, but actually aren't necessarily so difficult if only their needs were being better understood and supported. So yeah, it's just to say collaboration really matters. And thank you. And I've so enjoyed the discussion, and I'm sorry, but I have to go and prepare for another meeting in 5 minutes' time.
Thank you, Sheila. Thank you for coming, and it would be good to carry on the conversation after this. I've got Colin and then Vic, please.
Thank you. I'm mindful of time, so I'll be as brief as I can. I said right at the start of this, level-headedness as we come out of COVID and we're looking at the issues. I think government must concentrate on a long-term vision for adult social care, whatever that happens to be. I think it's far too short-term, and the LGA would be hugely supportive of making that particular point. We also make the point about funding. You know, we are very concerned that the council tax seems to be a short-term stopgap way to fund things, and as I say, it's a very regressive tax, and I think it will present a lot of problems for a very hard-pressed cohort who are worried about lots of things like their jobs and their health and their mortgage, and I think council tax just constantly going up doesn't help them. I think in the long-term funding, I probably more a personal view, but I think this point about insurance, about creating something for the number of people who do look after themselves, I find it ridiculous that I can insure most things in my life, but I don't seem to be able to insure against dementia or my long-term care needs, which seems wrong. I think there's an aspect of that, but I suppose fundamental to our approach, and something we would like to see, is this point about what is prevention. Is prevention about a medical intervention, or is it about being more active? Is it about access to public paths, access to cycleways, access to leisure facilities to keep people active? And is it about housing? Because I genuinely do think it is. I think when you look at the structure of government, that you have the Department of Health, you have the NHS, then you have MMCLG that does all the planning. Actually, I think this is wrong. I think if COVID has shown us anything, there is a dire need for a change in our housing policy to build more houses and to build things like extra care that is appropriate for an aging population. It seems utterly ridiculous to me that you produce all these statistics that talk about the seismic shift of our population into an older age group, and we don't talk about housing for them. And it just, I find utterly ridiculous. So those are the sort of areas I think the LGA would be very pleased to support. Thank you.
Thank you, Colin. And I think topically, of course, you know, those children who are studying homeschooling today, not only do they need Wi-Fi and equipment, but actually they need quiet space in which to study, you know, a dry, peaceful room. Vic, please.
Thanks very much. So I think, excuse me, the things to be signing up to would be clearly around investment and workforce planning, as we've talked about. But I think just for the BMA, just to be thinking about how any future is expressed as really a narrative of equals between health and care, and to think about that in not just in terms of a discussion about social care, but in terms of a discussion about all sort of change and reform around health in that context. So to always be having that kind of checkpoint within that, we talked a lot about integration, but also to be recognizing that social care has its own important and separate role to play. And I think for people, it's really important that we keep a very close focus on what that role is that people want social care to be playing now and in the future.
Thank you. I've temporarily run out of hands that are up, and we are at 12 o'clock. I think from my offer from the BMA, as well as offering my thanks, would be I think we've had agreement that people need understandable information so that they know what's available, whether they're privately funding themselves or will fall into that minority of people that are getting paid for social care. So there's this information. There's significant funding, there's the workforce strategy and a long-term vision that we need to be thinking more about integration of health and social care with this prevention strategy, which Colin, I would definitely endorse from the public health point of view, and intermediate care. I suspect we might have to think about our next steps now a little bit electronically and keep the dialogue going. I think please put your hands if you wouldn't be happy if the BMA made some sort of statement to say that we'd had a round table with a great deal of agreement that included the need for reform, that needed a continuous funding of the COVID funding in the immediate term, that needs more information for all of us, those in receipt of social care, those of us, any of us who could need social care, and that we perhaps will carry on the work of the vision with greater integration. We have discussed the opportunity and the lack of mention of social care in the consultation on the ICSs. The consultation date is shut. The BMA said this is the wrong time. This isn't enough time. Perhaps we should be all lobbying to get more social care into the ICS. Thank you all so much. Would anyone like to say anything other than I hope we meet again? I hope this is the beginning of a dialogue.
I'd like to say thank you, Helena. We recognise BMA is such a powerful voice, actually. So it's great that you are, as it were, taking on this task of enabling this dialogue. So we don't underestimate that. You are definitely listened to in a way that the rest of us sometimes aren't. So all power to your elbow.
Thank you. I think we would like to be listened to with you as well. So I look forward to this being the beginning of some dialogue. thank you all very much, and let's stay safe, keep up the good work together.
Thanks a lot.
Thank you.
Bye.
Bye-bye.